I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today I'm joined by Dr. Joshua Chodosh, Michael L. Freedman Professor of Geriatric Research at New York University's Grossman School of Medicine and staff physician at the VA Harbor Healthcare System. Dr. Chodosh is the director of NYU's Division of Geriatric Medicine and Palliative Care, which is a recipient of the Center for Disease Control, CDC's Building Our Largest Dementia, or BOLD, infrastructure Public Health Center of Excellence grant. The center's mission is to increase early detection of dementia nationwide. They promote the implementation of public health, clinical, and community initiatives focused on improving early detection, reducing stigma, and advancing health equity. Today, Dr. Chodosh joins us to talk about his work with BOLD, early dementia detection, and integrating public health and public policy into dementia care. Dr. Chodosh, welcome to Dementia Matters.
Thank you so much for having me.
To begin, I'd like to understand how you got interested in geriatrics and early detection of dementia.
Well, I first got interested in geriatrics because of the people that I knew at my institution at the University of Rochester who were geriatricians. Just an extraordinary group of just terrific individuals, great clinicians, and really committed to excellent healthcare, particularly for our oldest members of society. And I had the opportunity to participate in a curriculum project supported by the John Hartford Foundation that focused on bringing geriatric principles to primary care training. So that's really how I got started. And it was really working with those individuals that they seduced me, if you will, and said, Josh, you have to be a geriatrician. You're a geriatrician. You don't know it yet, but you are. And that is really what got me started.
And then geriatrics, though, is quite broad. There's a lot of important conditions that geriatricians specialize in. Why early detection of dementia?
Well, even before I got involved in that project, I became very interested in dementia for a couple of reasons. One, nobody was talking about it, and yet I knew it was present everywhere. And two, it was really through what I would really characterize as a medical error on my part. I was a chief resident at the time, and we had a busy outpatient internal medicine clinic, and my third year resident came to me, who, by the way, then became a geriatrician herself, came to me and said, Josh, we've got this lady, and you've seen her with me at least 3 or 4 times, and we just can't get her blood pressure under control. We keep upping her dose and adding medicines. And she's a delightful person, but I think she might be really impaired. She might have dementia because she didn't really even remember the last visit we had. And so I went in with her, and in those days, you used the mini mental state exam because there wasn't anything better, as bad as that instrument can be, and just started talking to her and asking her those kinds of questions. And it was pretty clear, though, even though she was able to find her way to clinic and she was very sociable and, loved being there, we loved seeing her, she was impaired. She really didn't know what was going on. And then when we did a home visit, not ourselves, but we had a nurse visit, they went to her home and she had all of her medications in unopened bottles, neatly placed on shelves. So she was getting her prescriptions, but she wasn't taking them. So that was really eye-opening for me and very humbling in terms of informing me about all the care we were not providing for our patients who were struggling with cognitive impairment.
Josh, you brought up a really good point of there's an increasing number of people with dementia, or at least there's a lot of people out there with dementia, but then there's a lot that are undiagnosed that we only later on find out that they're having these challenges. Why is that? Are healthcare providers good at identifying and diagnosing dementia? And why not? And what would be the reason if that's true?
I think they're getting better. That comment probably underlies my sense that we're not very good at it. We're not very good at it unless we're very intentional about it. And I've even recently had some disagreements with some colleagues about their professed ability to detect dementia. And in fact, what they really needed to do was identify mild cognitive impairment. And I said, before you worry about mild impairment, let's focus on all the severe impairment, moderate to severe impairment that you're missing. And we did a study actually several years ago to demonstrate just how poor we are at detecting dementia. And we focused on physicians who had patients for a minimum of 8 years in a large health system. And they were given a ruler on a piece of paper, and all they had to do was place an X anywhere beyond zero. And they got credit for patients that we had characterized through another study as being anywhere from cognitively normal to being severely impaired. Even if they put that X just a little past zero, they got credit. And even with that, it was something like for those that were moderately to severely impaired, 20% of physicians said those individuals were cognitively normal. And amongst those who were less impaired, only about maybe half physicians identified those individuals as having any impairment at all. So that to me, and I don't think that has changed all that much. And I say that because unless you probe, even with mild to moderate dementia conditions, patients can be in many cases, retain their sociability, may retain enough language for everyday conversations. And if the tasks or the questions are not very challenging, they may do just fine. And we'll have no idea that in fact they're really starting to lose many of their functional abilities.
That's such a good point, and I was gonna add that in my memory clinic, I will see very thorough cognitive testing before I go in to see my patient, and so often I am caught off guard by the fact that their testing shows such low scores, but when I'm talking to them for the first 5 minutes, everything seems perfectly fine, and people can cover, and they have their social graces, and they're just able to direct the conversation to what they're capable of remembering or talking about.
That's right. That's right.
And it is shocking to me how and I, I consider myself someone who an expert in this field, and I will continually be surprised at, "Are you sure this is the right testing? Because this person certainly seems like they're with it." So I guess it doesn't speak to the inability of healthcare providers, but the need to really dig deeper.
Yes. Yes.
But you've said something to me in the past, and you've asked some important questions. In particular, do we need public health to solve the problem of early detection of dementia? And before we go deeper into that question, though, I want you to explain to our listeners what exactly public health is and their role in healthcare.
Sure. So, I had to learn this actually when I made this application for this CDC grant because, most of us in healthcare don't really interact directly with public health institutions, structures, et cetera. That speaks to some of the siloed nature of our, respective work experiences. But public health is really, first of all, we should think of it as a structure, one that's organized, one that engages different kinds of people. Those are public health officials, their staff, volunteers, and they're organized to promote and protect the health of all people and all people where they live in their communities. It's not people within nursing homes. It's not people within, although they might address that. It's not people within the hospital, but it's people within their communities. And public health is really about the entire population and really has a population focus, while healthcare has much more of an individual focus, that being on individual patients. And while healthcare is really focused, for the most part, although we're getting better at it, but for the most part, really treating people who are sick, public health really aims at prevention, keeping people from getting sick, and in many cases, with respect to workplace, injured, in workplaces or on the streets, in the first place. So that really is, I think, a best way to describe this. And I think finally, when I think of public health, I do think of besides prevention, I do think about chronic disease because that is in fact where public health has focused much of their efforts and made a real impact. They have had much focus on hypertension. We've all seen some examples of that, whether it be through ad campaigns or clinics. Focus on diabetes, and I think where some of their greatest success stories have been in the arena of HIV, addiction healthcare, and infectious disease prevention through vaccination, particularly most recently COVID-19.
Now, part of your BOLD grant, you mentioned promoting advancing health equity. And so, what does dementia have to do with health equity specifically?
Well, with respect to health equity, when you think about it, when you think about what what are many of the factors that impact cognitive well-being or brain health, some people call it, or brain disease, and those are many of those factors are things that affect us where we live, our health behaviors, but also our environmental influences. And many of those factors, whether it be hypertension, whether it be exposure to excessive alcohol use, obesity, smoking, physical inactivity, air pollution, all those things are predominantly worse in under-resourced communities. And that really speaks then to a health inequity that is based on not only what you look like as a person, but where you live. And furthermore, I think health equity becomes particularly important because, in addition to the environmental influences that we all live with every day, there are the influences of either the presence or absence of adequate health care. And that also becomes a real health equity or inequity issue. If I have high blood pressure and I don't have a place to go to get treated, or if I have a place to go, but I can't afford the prescriptions that will lower my blood pressure, or no one's giving me the proper education that says, I ought to stop going to McDonald's, or, having, 10 pickles every day if I like deli, then I'm going to be at much greater risk for having elevated blood pressure. And even if you give me medication, perhaps, I may not get any better. And to me, and that really is an expression, I think, of an inequitable society, and particularly of health inequities. And all those things are things that are going to influence cognitive health or illness.
You've done a very nice job of explaining how it's not just disease arrow treatment, that there's so much more to this in society and culture and environment in healthcare. I don't know why you are anti-pickle or at least anti-10 pickles, but
No, I love them. That's the problem.
putting that part aside, one of the things that comes up for me is why does early detection of dementia matter then from the public health and healthcare perspective, from both perspectives? Because it seems like they're unified in this need for early detection.
Sure. So early detection is important because when we don't detect this problem, we miss an opportunity to prevent a crisis. I think that's first and foremost. And I think that is a really important premise of our center, which is dementia is manageable if we detect it early before crisis occurs. And that's one major aspect. And that crisis could be a major motor vehicle accident. That crisis could be a fall that resulted in a hip fracture and was expressly because that individual wasn't exercising good judgment. Maybe they were standing on the very top of a step ladder. Some of us with supposed good judgment might do that too. But I think it's more likely that these kinds of injuries will occur through a lack of awareness or a lack of good judgment, and in part because of some cognitive impairment or confusion. I think I would wonder. I have not seen this data, but I wonder how many pedestrian motor vehicle injuries occur, in fact, because people are inattentive, and maybe inattentive because of some cognitive issues. And so I think that's first and foremost, because that's something we can do right away. The other reason it's really important is because it then helps to explain a lot of things that people are otherwise struggling with, not understanding. Why isn't dad returning my phone calls? He must not, he must be mad at us. Or, Why do we have to keep bringing him back to the emergency department? He's already been given an explanation as to what to do. Why is his illness not getting any better? Or sometimes unusual behaviors, or it may in fact be that sometimes digging into detect the whole detection process should then reveal other kinds of impairments, most notably because they're common, sensory impairments, and they're generally invisible. We don't see hearing loss. We don't see visual impairment. We experience it both in ourselves when we have it, but also through others when they have it. But we don't necessarily translate the behaviors as being behaviors because of those conditions. And so I think the detection process itself then does much to reveal other potential problems and things that can in fact be addressed. And then I think finally it's really about relationships, and in particular most of the time when they're present, families, and tremendous amounts of family stress, family discord, family challenges, because not only is this a problem that perhaps they're hiding from themselves or from others because of the associated stigma, but perhaps it's creating stressors on them where without detection they can't get the services that might be available to them to relieve some of those stressors.
I think it's really important that you share this idea of crisis prevention because the other answers about understanding symptoms impacting relationships that I've heard before, Josh, but preventing crisis seems like a very honest answer to me. You're not trying to cure an incurable disease right now. You're simply trying to make it better for people by preventing a crisis. And that is something that's very achievable. That seems like a very pragmatic way of looking at it.
Yeah, yeah.
And I'm hoping then you can bring that back then to this important grant that you have, and we've talked about BOLD. I mentioned it in your introduction, but what exactly is BOLD, and what does this whole process hope to achieve?
So that's a short question that probably deserves a longer answer than we can do.
You have 2 minutes.
So what is well, Bold is a center, certainly, and it's a center that obviously works very closely with the CDC as a cooperative grant. And we have monthly meetings with our CDC program officials. But I think the best way to describe this is it's an opportunity to identify best examples, amplify those examples, and disseminate those examples for the rest of the country to benefit from. Examples in best care, examples in best strategies. So that's one aspect. And through that, the focus is really a tripartite focus, if you will. We want to focus certainly on persons, families, and communities. We want to focus on healthcare providers and organizations. And then certainly not, last but not least at all, is a focus on public health departments. And in the way we think about these, yes, these are distinct sectors, but they are highly interactive, or they should be. And I think then the other opportunity we have as a center is to, if you will, perhaps reimagine or revisit strategies that may in fact be drawn from other areas, maybe not specific to cognitive impairment or dementia, but are highly relevant. And I think that much of that is about the how to, the how to do this. If you're and the why is really important. So we've talked about this a little bit, why detect. And the how to really has to take a very broad focus, which I think is where we sit in an important space. And that broad focus is around, this is not a box checking activity. This is not I pulled out a screener, I saw whether or not they passed or failed the screener, and therefore I did my detection. Nothing could be further from the truth. This is really about a process of understanding, doing a little bit of a deeper dive, and then coming up with some immediate opportunities for making things better. And that really is born out of a conversation. So we focus a lot on conversations, how to have best conversations, and how to do so, not turning what would have been a 15 or a 20-minute visit if you're in a healthcare system, for example, into an hour visit, but best using the time that you have through strategies and how you present yourself and how you think about the problem and how you use certain words or language that are encouraging, not discouraging, and least stigmatizing. So I think that's what we've done in the center is really tried to put a lot of that literally to the page as examples and as offerings to the community of how best to have productive conversations around cognitive impairment and be in a position to then detect a problem when a problem occurs. And maybe you'll pull out one of those instruments, but maybe not. Maybe you don't need to.
Can you share with our listeners an example of a successful activity that utilized the strategies or principles that Bold is really espousing?
Wow, that's a really interesting question. I mean, if you're thinking about a useful strategy that we've identified, you know one better than I do, and that would be Wisconsin's dementia care specialists, that have really blanketed the state, as I understand it, and have made, and I when I was there, I saw this, have made primary care providers better at what they do through this interrelationship between this dementia care specialist knowledge base and intention with what primary care already does, and really being additive, not now you need to do this instead of that, but really being additive to what they already do and providing an infrastructure of support so that if a primary care provider in fact does detect a problem, they know what to do next and they know who else they can turn to for additional support or services without having to repeatedly reinvent the wheel, which is I think what a primary care provider must feel like when this might occur in their practice, depending on the demographics of their patient population, might occur, 3 or 4 times a week, but it isn't every day. It isn't like they're managing hypertension or diabetes, for example. So I think that's an example. And then I think in other aspects, a lot of this has really come from my own work as a clinician in how and that's changed over time about how I'm able to have productive conversations by starting from a point of strength, not weakness, and really asking people about their lives, what they're proud of, what they want to do next, and whether then they then have any concerns about whether they're going to be able to do that or whether they're noticing or what they used to do really well 10 years ago, do they feel like they can still do it that well? And do they have any concerns about that? And should we be focusing on some strategies to ensure that they continue to do that really well? That puts us in a place of talking about things like thinking and memory and takes us out of, I think, a more potentially stigmatizing place. So I guess those would be two very different kinds of examples.
Well, I appreciate you using the one from Wisconsin, as you know where I'm from.
Well, it's one of, I mean, not being solicitous here. I mean, it really, we've noticed certainly that this is really different. What's happened in the state of Wisconsin and with, those efforts, yours and your colleagues, is decidedly different. And I think other people have looked at this and are trying to take what's best for them to bring to their own strategic focus.
Well, when you've come to Wisconsin and you presented in front of our group of colleagues, you did speak about dementia care navigation and that this being a part of how we can deliver healthcare. How do you envision this? And how does this actually relate to this newly proposed guide model that's coming out of CMS?
Yeah, well, I mean, it relates a lot. I think the guide model is a very interesting and potentially useful translation of much of the work that many of us have done through our more efficacious studies around dementia care management. And those studies have really focused on the need for an interdisciplinary team, the need for real collaboration within that interdisciplinary team, the need for very focused and purposeful assessments to identify a menu, if you will, of what we identify as high prevalent problems so that we don't miss those important things. I mean, I think this is where this whole notion of preventing a crisis comes into play. It may not be a crisis point, but that problem identification might really speak to a crisis that's probably going to occur if we don't do something. I think it speaks to many of these elements. It's pretty extraordinary that CMS as a governmental institution is putting real resources to this and is putting a real organizational focus to this and a very specific one, a fairly data heavy focus, if you will, a dashboarding focus, which I think is really important. I don't know if in fact this particular model will be the answer, but I have a feeling it's an answer. I also don't know whether this model will be financially feasible given the reimbursement structures that CMS has created. And I've gone over this pretty carefully, and others have as well who are far better at this kind of analysis than I am. And I think the general word on the street is it's going to be hard to break even. And I have a feeling that maybe in some very specific places where some things are well organized, like I think there's two streams to this. There's the we've never done this before stream versus we already have a lot of this set up, so we want to take this on. I think in the latter, it's more likely to succeed for all the reasons that we all understand. But I think probably also from a financial standpoint. And then lastly, I think where this probably has the most legs, unfortunately, actually, will be in academic health centers because they're better equipped to do a lot of the ancillary and structural, evaluative kinds of things that CMS is asking entities to provide, which I think in some settings might just really draw up all the energy and bandwidth of those well-meaning individuals who want to just deliver really good care. So I think that's perhaps where some of the risk lies in this. Understanding this is a demonstration and they're trying to figure this out. It's I don't maybe you know the answer to this, but it's also not clear to me why this has been set up as an 8-year project, although certainly, by years 2 or 3, I think we're going to have a pretty good idea, at least within some participants, whether or not this is a viable proposition.
I mean, it's a good question. I don't have that answer, but I do appreciate your perspective that a team-based approach, a collaborative care model makes a lot of sense, that we should use the knowledge of other specialties and caregiver skills as we are looking at this best care option for people living with thinking change. With that, though, Josh, I want to ask you for our last question to end our discussion. What do you hope things will look like 20 years from now? Given your experience in the field, given what you're doing now, what does 20 years look like? And what has changed to make care better for people with thinking changes?
So 20 years from now, if current trends hold true, I think that perhaps we will, to some degree, to the extent that it can be, normalize much of what is now considered to be abnormal, meaning that we will have a different point of view as to what cognitive function looks like and the range of cognitive possibilities. That's somewhat separate from what I think of as some very distinct brain diseases that we all know what those are that really stand out as a real departure from day-to-day life and perhaps the experience of such individuals. So I think one of the things that I would hope to see 20 years from now will be less stigma. And I say that because even now, whereas like 10 years ago this wasn't happening, people will come into the office and say, Dr. Chodosh, I'm worried about Alzheimer's disease. I want to be tested. Would never have heard that 10 years ago. And that's not even because some people now have greater degrees of hope of having a treatment right now that might make that difference. That's part of it. But I think some of it is just the conversation, the volume has been turned up and the airwaves have become more saturated with this kind of topic discussion. And so I think that's made it more, it's like anything you do more than once, you have opportunity to become more comfortable with. And so I think that's part of what we're seeing now. I think and hope that we'll have in general a more socially focused healthcare system so that the things that we will pay for are not just drugs and procedures, but actual inter and intrapersonal care, that we'll have incentives, that people will be incentivized in one way or another to have better health behaviors. And I also think there's good reason to believe that we will see a lesser degree of cognitive disease. And I say that because I think we have gotten better at managing many of the conditions that we know are so strongly associated with brain health or illness, much of which is in the realm of metabolic disease. Even though there are some contrary forces at play here, I do think that we have opportunities at least for better health in our population. And better health in our population, I think, does translate into better brain health because brains are anything but innocent bystanders. You know, they're so central, and the blood-brain barrier, if you will, is a bit of a myth in respect to its vulnerability to lots of health conditions.
Well, thank you for ending on such a positive note, Josh. And I like this version 20 years from now. So I do hope we are moving in that direction. I want to thank you again for being on Dementia Matters. And I do hope to have you on in the future.
Love to be there. Thank you so much.
Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen. Or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Amy Lambright Murphy and Kaylin Rowerdink and edited by Eli Gadbury. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.